Hello everyone, thanks for stumbling across Resident ENT with myself, Josh Stramiello. This is a channel for medical students and residents to learn about and brush up on large topics or general topics in otolaryngology or ear, nose, throat surgery. And so today we're going to be talking about thyroidectomy. So just to recap a little bit, these are the levels of the cervical fascia. And when one of the common questions that attendings like to ask is, what layers do we have to go through to perform our thyroidectomy? So when we look here, black is the skin and subcutaneous fat, so we're obviously going through that. Then we're going to come through this orange layer, which is the superficial cervical fascia, which encases the platysma, or the thin muscle in the front that's touched by the cervical branch of the facial nerve to contract, and moves superior to be continuous with the SMAS. Just below the platysma, or the superficial cervical fascia, we then run into this blue line here delineating the strap muscles, the sternocleidomastoid muscles, and the trapezius, all within this layer of the superficial layer of deep cervical fascia. So of course we have to go through those as well to get to the goal, which is the thyroid. The thyroid here is green, and it's within its own level of fascia, which is known as the visceral fascia. Some people also like to call it the pretracheal fascia. So we're going to kind of go through this stepwise, and these two lines are going to delineate the neck of the patient. And most commonly, we make a horizontal incision about 2 centimeters inferior to the cricoid. That changes based on the patient's anatomy and the surgeon's comfortability and practice. After we make that incision, the first thing that we're going to come to is, so we'll just kind of open this up here. The first thing that we're going to come to is our platysma, and that's also going to be a horizontal incision there. And then for the most part, we have to spread the skin and the platysma in a superior and inferior direction to get to the next part. So the next part of the surgery, we've made our incision. It's nice and open, kind of like this big oval. And within there, and we'll just say these are the skin edges and the platysma edges. And once we get in there, the first thing that we're going to run into, besides some more fatty tissue, is going to be the strap muscles, which, if you remember, actually let's do this. This is our platysma, so we can keep our color coding going the same way. And so the first thing that we're going to run into are the strap muscles. And they're going to be on either side here. And the reason I'm delineating the center here is because that is going to be the median raphe. So let's just mark this out. So we have the strap muscles, and we have the median raphe. Now, the most popular PIMP question that comes from here is attendings always like to ask which strap muscle is first, because these are all, actually more appropriately, the infrahyoid muscle group, and there's 4 of them on each side. So just to kind of diverge for a little bit, if we have the hyoid bone here, and we have thyroid cartilage here, let's put the notch, we're going to have our 4 muscles, which we'll again delineate in blue. The deepest is going to be going from the hyoid to the thyroid cartilage, also known as the thyrohyoid muscle. The next one is going to be going from the thyroid cartilage all the way down to the sternum, or the sternohyoid muscle. The next one is going to travel the entire space as well, which is going to be the sternohyoid muscle. And then finally, we have another one that we don't generally see in thyroidectomy, but it is there, and it's a little bit more lateral, and it actually swings all the way out to the scapula. And we have a superior belly and we have an inferior belly. And this is called the omohyoid. So everybody forgets that one. But the very common pimp question that everybody likes to ask is, which muscle do you see first? And now when you're looking at these, I don't know if you can imagine in your brain, how could you possibly have a muscle that attaches from hyoid to thyroid cartilage and then thyroid cartilage to sternum with another longer muscle behind that? It's just impossible. So you always know that the sternohyoid muscle is going to be first. And there you go. You've impressed your attending. So to get back to the surgery here, let's draw out our neck again. We've opened up the median raphe and we've spread the muscles laterally. Okay? And so now what we have is our incision that's nice and wide open, a little exaggerated there. We have our platysma opened up to the sides. And now we have our strap muscles opened up laterally. Perfect. And at that point, we should basically be looking directly at the thyroid. And the thyroid, for the most part, is going to be hidden on either side, and your expert retraction is going to be very much appreciated by the rest of the surgical team so that we can get to the edges. So now let's talk about the most important anatomy of the thyroid and the thyroidectomy. I'm going to forego the picture of the neck, and we're just going to draw a thyroid. It kind of looks like this shape, give or take. And then we have some really important structures attached to it that we need to know. So the first is you're going to have an artery coming from the superior pole, and you're going to have an artery coming from the inferior pole. Okay? And then just to keep the paper clean, we're also going to have some veins that are coming in the area. The most important one comes off the kind of middle portion of the gland, but there is one coming off the superior pole and the inferior pole, and we don't think about those as much. So when we talk about the arteries, the common questions and really the knowledge that we need to know is, where are they coming from and at what level can we take them? And so the superior thyroid artery is actually and this is good to know, it's going to come from the external carotid artery. So this is the superior thyroid artery, and it's going to come from the external carotid artery, and it's actually the first branch of the external carotid artery. Some people would argue that maybe the ascending pharyngeal could be first, but usually that one's second. The more inferior artery is going to be the inferior thyroid artery. And for some reason, nobody can really remember where this comes from because it's so out of the place. You just can't even think about it, but the name, but the origin is in the name. And this is actually coming from, we'll just draw some extra anatomy there. It's coming from the thyrocervical trunk. So the thyrocervical trunk feeds the inferior thyroid artery. Sometimes, and anatomy books love to point this out, though it's not very common, sometimes you will have a bridging artery coming straight off the aorta or the innominate that's called the IMA. That's not an acronym, that's just the name of it. It's called the IMA artery. And so that's the arterial blood supply to the thyroid. Now, the venous is a little less important. It's a little bit variable, but we have the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. Really, the most important one for the surgery is the middle, because when we take down the arteries, when we ligate the arteries, we ligate the veins with them generally, but you don't have that luxury with the middle thyroid vein, so you always have to look for that one, and that usually gives you enough rotation to be able to see behind that pole of the gland, which is an important part of the surgery. So then the next thing to really talk about is the fact that we have 4 other glands that are sitting in close proximity to the thyroid, and so they have received the name parathyroid glands, and they create parathyroid hormone, which is important in calcium, blood calcium. So we'll just say this is the parathyroid gland, PTG. We have 4 of them, and these are important for a couple reasons, mostly because you'll get pimped on it. But really what it is they help us define where the recurrent laryngeal nerve is going to be headed. And so for the most part, the nerve is going to kind of travel in this direction on either side. One's a little bit more oblique. The left one is a little bit more oblique. But what ends up happening is then we know that the inferior parathyroid gland is going to be ventral or in front of the nerve, while the superior parathyroid gland is going to be dorsal or posterior to the nerve. And again, this is just another feature that we can use to make sure we keep this nerve safe. The other thing to know is that both glands receive their blood supply from the inferior thyroid artery. So we can be much more liberal in ligating the superior thyroid artery, but as we're cleaning the parathyroid glands off of the thyroid gland, we have to be very cognizant that we're not ligating the inferior thyroid artery, proximal to their branches to these glands, because then otherwise they might not be functional. So great, that's the important parts of that. The other thing to know is, where do the recurrent laryngeal nerves come from? So again, these are the recurrent laryngeal nerves, and as we know, they come from cranial nerve 10. The important thing about that is that they both loop around large blood vessels. And sometimes this can be kind of hard to remember, which is which. But the one way that I remember, and I think is the easiest, is you have to remember that just one of them wraps around the aorta. And if you know that, then you know which one, because the aorta only goes one way. The aorta only goes to the left. And that's why we have these branches of the innominate that come to hit the subclavian or feed the subclavian. And then we know that the right recurrent laryngeal nerve wraps around the subclavian and the left around the aorta. Just remember that one of them always wraps around the aorta, and then you'll know exactly which one, because the aorta always goes to the left. So let's just mark this. This is aorta. This is innominate, or the unnamed artery. And there you go. So as the procedure goes, we need to ligate the arteries. We need to peel the parathyroid glands off of the thyroid. We need to ligate the veins as well. And then basically, for the most part, the thyroid gland can slowly be removed once the recurrent laryngeal nerve is identified. So, this diagram really doesn't depict the ability to do the surgery, but it'll give you a really good idea of what's important and what we're looking at. I know it's a crazy jumbled mess, but if you just take the time to follow through with it, it makes a lot of sense, and it's a little bit more stepwise and easier to follow. So again, thanks for tuning in to Resident ENT. I hope this was helpful. I'm excited to see any comments that you might have to say how we can make this more beneficial, or any questions you have that you think I could answer for you. I'd be happy to do so in the comments below. Otherwise, thanks for tuning in.